Neurology quiz number 28. What are the types of Creuzfeldt Jakob disease or CJD and what are their clinical features? CJD is a prion disease. Prion stands for proteinaceous infectious particle. Prion diseases are caused when normal prion protein or PRPC, which has an alpha helical structure, is converted into an abnormal type PRPSC or prion, which has a beta pleated structure. PRPC may play a part in neuronal development and is encoded by the PRNP gene on chromosome 20. Prion diseases are also called transmissible spongiform encephalopathies, as they share a similar non-inflammatory spongiform pathology. CJD types include sporadic, genetic/familial, acquired/variant, and iatrogenic. Sporadic CJD clinical features. This usually occurs from 50 to 70 years of age. Symptoms vary widely and are as follows. Subtle early symptoms include irritability, anxiety, depression, and constitutional symptoms such as fatigue, malaise, headache, and vertigo. Cognitive symptoms include confusion, difficulty concentrating and planning, memory loss, and dementia. Motor manifestations can be extrapyramidal, such as bradykinesia, tremor, and dystonia, cerebellar, such as gait or limb ataxia, and later myoclonus. Visual symptoms are secondary to processing of visual information in the brain and include blurred or double vision and cortical blindness. Aphasia, apraxia, or neglect may occur secondary to cortical dysfunction. Progression of the disease can lead to an akinetic mute state. Sporadic CJD is typically very rapid, with a median survival of 7 to 8 months, and more than 90% of the patients are dead within 1 year of onset of symptoms. Pathological features include loss of neurons, astrocytic proliferation with gliosis, vacuolation or spongiform change, and deposition of PRPSC, which is a feature required for definitive diagnosis. Sporadic CJD is of 6 molecular subtypes based on the genetic polymorphism at codon 129 in the prion gene. CJD pathology. Figure 1 is cortex showing large intracellular vacuoles and spongiform change, and Figure 2 shows coarse PRPSC deposits, which are demonstrated by immunohistochemistry. Investigations. EEG. The typical EEG finding is 1 to 2 Hz periodic sharp wave complexes, biphasic or triphasic, and is seen in 70% of the cases, period. However, this finding may not be detected until later stages of the disease. Brain MRI is highly sensitive and specific. 91 to 96%. Cortical hyperintensities or cortical ribboning is seen on DWI, which is the most sensitive, and flare sequences. Also noted is restricted diffusion/hyperintensity in the caudate nucleus, putamen, and thalamus. CSF is usually normal except for mild elevation of protein. Utility of CSF biomarkers like 14-3-3 protein, neuron-specific enolase, or total tau is limited, as these proteins are not prion specific. RT-QuIC or real-time Quicking induced conversion test is very reliable. CSF from a patient is added to a mixture of recombinant PRP and thioflavine T. Any PRPSC present in the CSF binds to recombinant PRP and induces it to change shape and form amyloid fibrils. The fibrils bind to thioflavine T, which starts to fluoresce, and fluorescence is monitored in real time. It has a 96% sensitivity and 100% specificity for CSF. Modifications of this test have also been used for testing blood and urine. Diagnostic criteria for CJD include the UCSF and European criteria. This is an EEG showing periodic discharges in CJD. This is a diffusion-weighted MRI showing cortical ribboning and restricted diffusion in subcortical structures. This is a slide showing diagrammatic overview of the RT-QuIC test. Genetic CJD or familial CJD. This is the most common genetic prion disease. It is autosomal dominant and can be caused by more than 15 different PRNP mutations. The most common mutation is E200K. Onset is between 30 and 55 years, and clinical, radiologic, and neuropathological features resemble sporadic CJD. It is more common among Sephardic Jews and Slovakians. Other genetic prion diseases are Gerstmann-Straussler-Scheinker syndrome and familial fatal insomnia, which will be discussed in a future quiz. Acquired CJD or variant CJD. Acquired forms can occur as prions are transmissible. Variant CJD occurred mainly in the United Kingdom and France and was secondary to consumption of beef contaminated with bovine spongiform encephalopathy or mad cow disease agent. This was most likely related to the practice of feeding sheep products contaminated with the prion disease scrapie to cows. Food products derived from infected cows were ingested by humans, some of whom developed variant CJD. It was first identified in the UK in 1994 to 1995, and cases declined after the year 2000 after corrective measures were instituted, and no new cases have been reported after 2012. Median age of onset is much younger than in the sporadic type, 27 years, and median duration is also longer, 15 months. It begins with a psychiatric prodrome a few months before the onset of neurologic symptoms, and later patients develop cognitive deficit, cerebellar dysfunction, and involuntary movements, including myoclonus and dystonia. PRP-SC invariant CJD is detected not only in the CNS but also in the lymphoreticular system, as the disease is acquired through the oral route. MRI may show the pulvinar sign with hyperintensity of the pulvinar on T2 and DWI. It is seen in 75% of the cases and is rare in the sporadic type. The double hockey stick sign with bilateral hyperintensity of the medial and posterior thalamus is seen in both the variant and the sporadic type. The other acquired prion disease is Kuru, which will be discussed in a future quiz. This is an MRI invariant CJD showing the pulvinar sign and the double hockey stick sign. Iatrogenic CJD, human-to-human transmission of CJD has occurred, and most commonly with cadaveric human pituitary growth hormone extracts and duramater graft transplants. It has also occurred with infected corneal transplants, e.g. depth electrodes, and blood product transfusions. As a prion is a protein and not a viral or bacterial agent, it cannot be eliminated by the usual decontamination methods. Preventive methods include strict screening for CJD and special procedures for prion decontamination. Kuru is the only other prion disease with human-to-human transmission.